All right, everybody, if I could invite you to sit down, get and prepare ourselves for the second session, which are our oral presentations from our proffered abstracts. There'll be 6 presentations, and they'll be the session chairs are myself and my colleague, Dr. Ghasemiesfe. Did I pronounce that right? Oh, yeah, we're good. Okay, very good. So if I could invite you to sit down, and then Reza, would you like to introduce the first speaker? Yeah. So,
all right, thank you, everyone. Thank you for attending this great conference. These ideas from Shark, actually, they were awesome, right? So I'm sure they are going to have a hard time choosing the best, the winner. All right, so now we have the oral session. We start with clinical abstracts, and then we go to the PhD non-clinical abstracts. So the first presenter would be Dr. Mary Getz. She's one of our best, actually, residents. And the title of the abstract is Prevalence of Malignancy Among Incidental Indeterminate Adrenal Nodules on Contrast Enhanced CT in Patients Without Known Cancer, a multi-institutional study. I think it's a very impactful study. All right, Mary.
Right, thank you. I'm happy to share this multi-institutional study. We'd like to thank all of the authors that helped us. Here are the institutions, and we have no disclosures. So an incidental adrenal nodule is an adrenal lesion found on cross-sectional imaging performed for reasons unrelated to primary adrenal disease. They're actually pretty common, seen in 4 to 5% of adult CTs. Most are benign adrenal adenomas, however, rarely may represent primary malignancies such as adrenal cortical carcinoma. A nodule with an unenhanced attenuation, 10 Hounsfield units or less, is diagnostic of a benign lipid-rich adenoma. However, most adrenal nodules are first seen on single-phase contrast CT, which cannot reliably differentiate benign from malignant. So further imaging is typically recommended. And here's an example. Management of incidental adrenal nodules is controversial. The risk of adrenocortical carcinoma is increased in nodules 4 centimeters or greater. Therefore, further evaluation is warranted. However, below 4 centimeters, evidence is limited and recommendations vary. For example, the American College of Radiology white paper recommends consideration for 1-year follow-up CT for indeterminate nodules 1 to 2 centimeter and immediate CT of 2 to 4 centimeter. However, the European Society of Endocrinology recommends follow-up immediate CT for all indeterminate nodules greater than 1 centimeter. Therefore, the purpose of our study is to assess the prevalence of malignancy in indeterminate incidental adrenal nodules on contrast-enhanced CT in patients without known cancer and to stratify the risks of malignancy by nodule size. This was a retrospective multi-institutional cohort study. We first reviewed consecutive contrast-enhanced CT reports in adults using the keywords listed here. Over 10,000 CT reports were reviewed. We excluded cases with nodules measuring 10 Hounsfield units or less, exams performed for an adrenal indication, and patient history of cancer. First, reports were reviewed, and if the report stated normal adrenal glands, no images were reviewed. Otherwise, images were reviewed to identify eligible nodules that were 1 centimeter or greater and greater than 10 Hounsfield units. Our reference standards included pathology, when available, separate imaging that was diagnostic of a lipid-rich adenoma, either by unenhanced CT or chemical shift MRI. Imaging follow-up showing stability 1 year or greater from the index CT, and clinical follow-up showing no evidence of adrenal cancer 5 years or greater from the index CT. Our final cohort included 1,506 nodules in 1,320 patients. And here are the different reference standards. The most common were unenhanced CT and imaging stability. This chart shows the distribution of the 1,506 nodules by size, approximately half for 1 or 2 centimeter, a relatively small sample size, 3 to 4 centimeter, and an even smaller sample size, greater than 4 centimeters. And here are the different pathologies. The angiosarcoma was felt to be a collision tumor, as this occurred 6 years after the index CT, which showed a lipid-rich adenoma. Therefore, the original nodule is considered benign. We did have a single case of malignancy. On index CT, it was a 2.7 centimeter indeterminate nodule. The patient presented 9 years later, and it had grown to 4 centimeters. The adrenal gland was resected, and pathology did meet criteria for an ACC. So for nodule size, 1 to 2 centimeter, there are 0 cases of malignancy, and the 1 malignant case was 2 to 4 centimeters. No cases greater than 4 centimeters, although there was a small sample size. Overall, the prevalence of malignancy was low at 0.0%. This table shows that there is no significant difference in the prevalence of malignancy between nodules 1 to 2 centimeter and 2 to 4 centimeter. Limitations of our study included a retrospective nature, and imperfect reference standard in most cases where pathology was not available. This likely underestimated the prevalence of pheochromocytoma, as our reference standard was designed to detect malignancy. In conclusion, the prevalence of malignancy among incidental indeterminate adrenal nodules less than 4 centimeter on contrast-enhanced CT in patients without cancer is extremely low. The prevalence of malignancy among nodules 4 to 6 centimeters is low, although the current study had insufficient sample size. There's no difference in malignancy rate noted between nodules 1 to 2 centimeter and 2 to 4 centimeter, though again, relatively low sample size for 3 to 4 centimeters. Imaging follow-up of small 1 or 2 centimeter incidental indeterminate adrenal nodules is not warranted. The specific size threshold above which follow-up is appropriate remains unknown due to small sample size of larger nodules. Thank you.
Any questions? I think we have time for one question, maybe. Thank you for a great presentation. Mike, go ahead.
Yeah, we've thought about it because it seems like it was very slow growing. But we kind of looked at the pathology report and the criteria that the pathologists have, and it did meet criteria for like a oncocytic ACC based on the criteria that they had.
Okay, but yeah, but the 9-year gap kind of like how malignant is that? But thank you.
Yeah, so it's a great question, and Mary's right. So for oncocytic ACCs, it's actually quite easy to get to the diagnosis of ACC compared to non-oncocytic, and there are pathologic based on genetic mutations that result in the ACC. Pathologically, there are classifications of ACCs
some of which are actually quite indolent. And so talking to pathologists, they're like, you know, getting to an ACC diagnosis, particularly for oncocytic, is actually pretty easy. And so they can be slow growing like this. We had a lot of debate of what to do with this case, but ultimately it met WHO criteria, so we had to call it. Yeah, but it's a great question.
All right, thank you so much, Mary. Great presentation. All right, so the second presentation would be by Andrew Chen. Is I think one of our fourth-year residents again. The title of the abstract is Comparison of 1.5T Deep Learning Reconstruction versus Conventional 3T in Shoulder MRI, a preliminary subjective assessment. All right, thank you.
Hey everyone. First off, just want to say thanks so much to the organizers for putting the event together and for giving me the opportunity to present our team's work. Our project was supported by an NIH grant. And before we jump into things, here's the little guessing game that we can play. Here's two scans. Both of these are shoulder MRI exams, panel A and panel B, one of which is a 1.5T scan with deep learning reconstruction, and the other of which is a 3T scan with conventional reconstruction. So take a look at these images, give your guess, and we'll come back to this later. So AirRecon DL is a deep learning software for MRI, and it's intended to improve signal to noise ratio, reduce noise and artifacts, and shorten scan times. And we use this at our institution on a couple of our MRI scanners. And really the motivation for this study was that one of our MSK attendings, Dylan Chen, noted in his day-to-day work that the quality of the MRI exams on the 1.5T scanner with deep learning reconstruction, which I'll refer to as DLR, was really so good and so impressive that it could be comparable to the standard 3T scans. This group from Japan from a couple of years back put out this paper showing that for knee MRI, 1.5T DLR was superior to conventional 3T in both subjective and objective image quality. So our purpose was to compare for shoulder MRI at 1.5T using DLR compared to conventional 3T. Our study design was a retrospective review of 98 1.5T DLR exams and 83 conventional 3T exams. And we had 3 blinded graders who evaluated all exams twice, separated by a 4-week washout period. There were a number of imaging quality metrics that we assessed on a 5-point Likert scale as listed below here. And there were some additional variables that each of the graders assessed, namely the full thickness rotator cuff tear graded as present or absent, labral tear graded as present, possible, or absent, and each grader also guessed the magnet strength or scanner type. This is just a table showing our 5-point Likert scale where a grade of 5 indicated the best image quality or no noise and artifacts. Moving into our results, the demographics for the study, for whatever reason, our 1.5T DLR cohort showed a slightly higher proportion of female patients, but otherwise our two groups were similar in terms of mean age, rate of prior surgery in the index shoulder, and the proportion of full thickness rotator cuff or labral tears. Also some example cases here. This is a 1.5T DLR case. This was assigned an overall image quality of 3.8, and most of our graders correctly identified this. Another 1.5T DLR case with a slightly higher overall image quality of 4.3, and all of our graders correctly identified this. This is our 3T case. Immediately, you can see, it might not be projected the best here, but there is a bit more noise, a bit more artifact. So this was given a mean overall image quality of 3.0, and most of our graders correctly identified this as 3T. And lastly, this case with slightly higher image quality of 3.5, and our graders were split 50-50 on the scanner type. In terms of identifying the scanner type, we see here that our MSK faculty were actually very accurate, especially compared to our humble radiology residents. And all of our image quality metrics were significantly higher for the 1.5T DLR cohort. Here we have rotator cuff image quality with the dots indicating the mean Likert value, and the error bars are the standard deviation. But we saw the same pattern across the board, including for labrum image quality, noise, artifacts, and overall image quality, which was really our most important variable. So our 1.5T DLR scans had a mean Likert value of 3.48 compared to 3.18. So to assess the validity of our study, we looked at intra-grader agreement between rounds 1 and 2. Here we see that for our quality metrics, our Cohen's kappa values corresponded to moderate to good agreement. And for our evaluation of tear, there was good to excellent agreement. And for inter-grader agreement among our 3 graders, for full thickness rotator cuff tear, we had Cohen's kappa values corresponding to good agreement, and for labral tear, corresponding to fair to moderate agreement, with kappa values around 0.4, which correspond or similar to those were previously reported in the literature. So here's that first slide again. So scan A is in fact a 3T scan, and scan B is a 1.5T with the deep learning reconstruction. This is just one example showing our overall conclusion, which is that shoulder MRI exams obtained at 1.5T with DLR showed higher overall subjective image quality with less noise and artifacts than conventional 3T. So one of the more interesting questions that we think is posed from our findings is if deep learning reconstruction could reduce the need for MR arthrograms. In 2023, the SSR put out consensus recommendations that for the evaluation of rotator cuff tears, conventional MRI is already first line, but for assessment of shoulder instability, they noted that direct MR arthrogram still has a compelling role in the assessment of especially younger individuals with shoulder instability. But potentially as deep learning reconstruction becomes more advanced and the image quality gets better and better, we may be able to reduce the need for invasive arthrograms. Some limitations of our study, it was retrospective and subjective, and there were certain factors that we didn't control for, such as the shoulder coil type or denoising factor. And unfortunately, we didn't have surgical arthroscopy findings for comparison. So for future directions, we do hope to eventually remedy that with the shoulder arthroscopy findings. Currently, that's limited by our sample size because relatively few of those patients ultimately went to surgery. And we may also want to compare other joints, do a similar comparison to other joints. Thank you so much.
All right, thank you so much, Andrew. Great work. Any questions? Up to 1, actually. Andrew.
Okay. So was there a rationale for not comparing against 3T with deep learning reconstruction? That's one question. And then the other one is was this the optimal 450 1.5T in the ACC, or can you, I might have missed it, but can you elaborate on what scanners were used for the 1.5? Obviously GE for the 1.5, but for the 3T as well, please.
Yeah. So the ACC scanner, the mobile 1 scanner was the one we used. So that was the deep learning reconstruction enhanced one. The 3T scanner was Siemens Vita. Yeah, Siemens Magneton Vita. That was the scanner that was used for the conventional 3T images. In terms of why we didn't include the 3T with DLR cohort, actually, one of my colleagues, Ethan Redzinski, had performed a very similar study to this one where we compared 1.5T with DLR versus 3T with DLR. So that was kind of a separate study. For this one, we specifically wanted to see if the 1.5T with the DLR enhancement would make it like superior to the conventional 3T. And so that's why we kind of separated it here. But it would be interesting to compare that data head to head. We actually haven't done that.
Chris, you had a question? Someone else? Okay. All right, thank you so much, Andrew. It was a great presentation. All right, now we have the third clinical presentation. It's going to be done by one of our UC Davis medical students. He's been involved in many researches in radiology. His name is Kamhung Lam. I know that he goes by Victor. And the abstract that he's presenting is validating a study of pulmonary nodule measurements using ultra-low dose technique with helical CT scout imaging. Victor, please.
There we go. All right, thank you so much. Hello, everybody. My name is Victor. I'm a third-year medical student with the Cardiothoracic Advanced Research Lab here. And today I'll be presenting our study, the validation study of pulmonary nodule measurements using ultra-low dose silver beam filtering technology. Here are my disclosures. This was done independent of our research agreement with Canon. Lung cancer is a leading cause of cancer death in the United States. Although death rates have drastically decreased due to successful efforts in tobacco cessation and improved cancer therapy, cancer survival remains poor largely because incidental cases are found in the regional and distal stages. Thus, early lung cancer screening using CT plays a crucial role in early detection for treatment and long-term survival. The current medical guidelines support the use of low-dose CT for annual lung cancer screening. The radiation risk of standard CT of the chest is roughly about 6.1 millisieverts, compared to that of a low-dose CT of about 1.5 millisieverts. While there is overall increased lifetime benefit, there's still concerns for increased risk of radiation-induced cancer, and as clinicians, we also want to minimize the radiation for our patients. Our scanner utilizes ultra-low-dose helical CT with a silver beam filter for 3D landmark scout imaging instead of the traditional 2D scanogram. The silver beam is used to achieve ultra-low doses. And using post-processing deep learning reconstruction, we attempted to repurpose these 3D landmark scouts into viable diagnostic 3D landmark scans for opportunistic screening without any additional imaging. These reconstructed scans are similar to an ultra-low-dose CT with a dose about like that of a chest X-ray, about 0.2 milligray or 0.1 to 0.2 millisieverts. And the purpose of this is to really assess the accuracy and the agreement of lung nodule measurements on standard CT compared to our reconstructed 3D landmark scans for possible lung cancer screening and nodule follow-up. And this was really following the promising results of an initial pilot study where we had 22 nodules measured, and we really expanded our sample size to validate and strengthen our findings. Here we have a brief video of the standard scanning sequence. From selecting the protocol, acquiring the 3D landmark CT, and generating the 2D planar images, and then using those images for automatic landmark detection. This entire process is automated. The technologist would then use this data to kind of plan the diagnostic study. And what's really novel about this work is that we hypothesized this 3D landmark scan is sufficient for lung cancer screening if a denoising step was added to the workflow. This is a static schematic. The 3D landmark scout uses the same dose as a 2D scanogram, as I mentioned, to determine the proper scan length for the indicated diagnostic scan. Using this already existing data, we reconstructed those scans. So effectively, at the very end, what we have are two series to compare. One that is created per standard of care, and another without any additional dose. This is another image comparison between the conventional 2D scout scan and the 3D landmark scan used in our study. And on the right side, what we have is the specific acquisition details of these 3D landmark scouts. So our expanded retrospective study included 37 additional patients with reported nodules found on various chest CTs. We reconstructed these 3D landmark scouts into 3D landmark scans captured at these settings and the settings prior slide. Lung nodules on standard CT scans and reconstructed 3D landmark scans were then measured independently by 2 board-certified radiologists. Here are our results. 53 nodules were detected with an average diameter of 9.8 and 9.4 millimeters on standard CT and 3D landmark scans, respectively. And the median was 6.45 and 6.4, respectively. Smallest nodules detected was 3.2 and 2.7, respectively. And the largest nodules detected was 38 and 34.7 millimeters, respectively. Here's a sample standard CT scan on the left side, and then the reconstructed 3D landmark scan on the right side, demonstrating a 4 millimeter micronodule. Here we have the same thing, standard on the left side, reconstructed on the right side, demonstrating an 8 millimeter solid nodule. Here we have a bigger nodule, a large 20 millimeter solid nodule. We measured the degree of correlation of lung nodule measurements for each reader, reader 1 on the left side and reader 2 on the right side, between the standard CT and 3D landmark scans statistically using the intra-class correlation coefficient. What we have here on this slide are 2 linear regression plots showing high association, and their ICC are of high values. We then also measured the concordance of lung nodule measurements between the 2 different readers for each CT modality. So the inter-observer agreement. On the left side here, what we see are simple linear regression plots, reader 1 versus reader 2 delineated by the different types. And on the right side, what we see here is the blind Altman plot for visual representation of the intra-class correlation coefficient that's depicted on the top right corner. These statistics on this sample showed excellent reliability and consistency. Specifically on the right plot, what we really want to see are those points close towards the median and kind of encircled in between the 2 standard deviations. These are incidental nodules. So we utilized the Flesher Society guidelines to stratify these lung nodules in both standard CT and 3D landmarks, measured with the qualitative reliability agreement using Cohen's quadratic weighted Cohen's kappa. Our statistics of 0.94 on this sample can be interpreted as almost perfect agreement. Now, what if we use the lung rats to risk stratify these lung nodules? Our statistics show 0.95 on this sample and can also be interpreted as almost perfect agreement. We have some data on the radiation doses. So we compare the CT dose index, the DLP, and the effective radiation dose in standard versus 3D landmark scans. And each variable shows significant lower dosages when compared to the standard CT. In conclusion, the accurate lung nodule measurements can potentially be obtained on the 3D landmark scan imaging using ultra-low dose protocol, a dose that's comparable to a chest radiograph. The potential reduction is from a standard dose of 1.5 millisieverts to an ultra-low dose of 0.1 to 0.2 millisieverts. This can be a cost-effective and safe screening strategy built into every routine CT scan. The diagnostic application of these 3D landmark scouts and ultra-low dose CT is a new and active field of investigation. Thank you.
Thank you so much, Victor. Any questions? David? Can you push on that bottom, the microphone?
Thanks for the really interesting presentation, Victor. That's really fantastic. My question is, were all the nodules that were looked at in this study solid pulmonary nodules? And I guess subjectively, I know you looked at specifically size measurements, but do you think these nodules seen on the deep learning reconstruction 3D landmark scans can be differentiated between solid pulmonary nodules, part solid nodules, and ground glass nodules?
Yes, that's a great question. So in terms of determining the nodules and risk stratifying them, it's important to look at the morphology and the sizes. We only looked at sizes and we only looked at solid nodules. Of the other nodules that we actually looked at that are not included in the study, we could actually tell the characteristic morphology differences. So we have seen like ground glass opacities, ground glass nodules, and subsolid nodules, but those were not included in this study.
Thank you so much. Great presentation.
So I'm going to be chairing the second half of this session, which is all the PhDs. And our first talk of the second half will be given by Dr. Shivani, who will be giving us a talk entitled Evaluation of 18F FAPI74 Total Body PET as a Quantitative Biomarker for Fibrosis Staging in MASLD. Dr. Shivani.
Good afternoon, everyone. Today I will be presenting on evaluation of FAPI total body PET as a quantitative biomarker for fibrosis staging in MASLD. MASLD is not only a fatty liver, it consists of fat accumulation along with at least one cardiometabolic risk factors. It affects around 40% of global adults population, making it the most chronic liver disease in the liver. As it progresses from simple steatosis to fibrosis and cirrhosis and ultimately leading to the liver failure, its early detection is really essential to prevent irreversible liver damages. So just look to understand this disease a bit more, let's look at the liver a bit closely. So here, how the microscopic at microscopic level, normal livers look like. I won't go in detail here, but these hepatic cells are the key point which I'm trying to make here. In normal liver, they are inactive and they store vitamin A, but during the chronic liver disease, they get activated, transdifferentiate into the myofibroblast cells, and then start the production of the extracellular matrices, which then leads to the fibrosis. Importantly, this activated HSC expresses high level of fibroblasts, fibroblast activation protein, which is called FAP. These are transmembrane serine proteins, which means that their active site is located on the surface of the cell, which make it easily accessible for imaging tracer. Beyond being a biomarker, this FAP so FAP actively promotes the fibrosis by activating, or I would say over-activating the antiplasmin, which inhibits this whole process called fibrinolysis. Then as a result, the scar formation surpasses the scar resolution, making the fibrosis progress more. So because it's low in normal liver and highly upregulated in chronic liver disease, it means that it can be used as a ideal imaging target for FAPI PET. So currently non-invasive diagnostic tools provides the indirect measures of liver stiffness or biochemical changes, where liver biopsy is still gold standard. Gold standard, but it's invasive. So there is a clearly unmet need of direct, non-invasive, quantitative diagnostic tool to image these fibrosis, and that's where FAPI can be used as it binds selectively to the FAP. So based on this rationale, our study aims to understand the biodistribution and performance of the FAPI in both healthy and confirmed MASLD patients. So for this study, we enrolled 10 participants. 3 were healthy, 4 had mild to moderate fibrosis, and 3 had advanced fibrosis, and these stages were confirmed by the pathology. Each participant underwent PET-CT scan for 60 minutes just after the administration of tracer. And for the purposes of analysis, 8 liver ROIs were placed on quino liver segments, along with the one on descending aorta for the references. To quantify the liver FAPI uptake in liver, we are looking at these 3 quantitative metrics. SUV, I think everyone knows that. Standard uptake value ratio is used to reduce the inter-individual variability by calculating the liver to blood pool ratio. Then by using the kinetic modeling, we estimate the net influx rate, which defined as the rate at which the tracer moves from blood into tissue and binds to its biological target. So here you can see the time activity curve averaged over all the 8 liver segments for all the participants grouped by their fibrosis stages. So just by 5 minutes post injection, we see the strongest separation between the healthy liver and fibrotic liver. To visualize it much bit more better, here you can see the plot showing the SUV values at 5 minutes, plotted over the fibrosis stages, showing that the increased tracer uptake with advancing fibrosis severity. Similarly, we did the same with SUVR, which shows the same trend, but more clear and better separation between the stages. So we further correlate these matrices with the fibrosis stages. And here you can see that the SUVR shows the strong correlation with the histological stage, which highlights its potential as a quantitative metrics of active fibrosis. Finally, we looked at the KI, which also was plotted across the fibrosis stages, and it also shows the same trend, showing that it increased progressively with the fibrosis stage, and correlation is also positive and strong. But SUVR still outperforms these 2 matrices. So just to conclude my presentation, our study demonstrated that FAPI can be used as a direct and quantitative assessment for the hepatic fibrosis. SUVR 5 minute, at least in this case, shows the strongest performance among all the PET metrics. To my knowledge, actually, this might be a very strong statement to do. This is the first application of FAPI PET in MASLD. And we'll be doing phase 2 with the study to make sure that these results persist further. Thank you.
Thank you, Dr. Shivani. We've got time for maybe one question.
Very interesting results. There's been work also using FDG as a marker in this case. So how do the FAPI results associate with those from FDG? Has there been any studies?
Yeah, and they have shown that FAPI outperforms like FDG results in case of fibrosis itself.
So better correlation?
Oh, better correlation.
Got it.
But not the timing, not the, yeah.
Okay, let's thank the speaker one more time. And our next presenter is Dr. Jinil Park. And his the presentation will be highly efficient and robust direct myelin imaging using inversion time-resolved interleaved ultrashort echo time, TIRI-UTE. Dr. Park.
Thank you for introduction. My research topic is highly efficient and robust direct myelin imaging using inversion time, resolved interleaved ultrashort echo time. It's called TIRI-UTE. First, myelin is insulating sheath around the axon. It protects nerve fibers and increase signal speed and efficiency. When myelin damages, it can lead to neurodegenerative disorder. But myelin imaging is challenging because myelin has an ultrashort T2 about 0.3 millisecond. So conventional MRI can capture this signal. However, UTE can acquire ultrashort T2 signal because UTE can set the TE under 0.1 millisecond. Therefore, UTE is widely used for tissue with ultrashort T2 and T2 star, such as lung and MSK and bone imaging. In our previous research, we found a correlation between UTE signal and myelin concentration. Even with our UTE, we have a problem. Long T2 water obscure ultra short T2 myelin. To address this, we use the IR-UTE, which suppress the long T2 signal component. This is a IR-UTE sequence diagram, and this is a signal mechanism. First, we applied inversion recovery pulse, and then we acquire UTE data at the null point of white matter. Yeah. So as you can see, this is a IR-UTE image. Myelin remain the myelin signal and minor long T2 signal here. And then we acquire second echo after UTE subtraction to remove the remaining long T2 signal. Myelin signal remained the first echo, but myelin signal fully suppressed in second echo. So subtracting second echo from UTE gives myelin contrast imaging here. But IR-UTE still has a limitation. Conventional MRI IR-UTE suppressed long T2 by nulling specific T1. However, weakness is T1 variability. As you can see in the brain T1 map, because T1 value in the center and outside are different, so they cannot or suppressed with one TI. And also T1 varies across the individual subject. For example, has control and epilepsy patient shows the different contrast with the same scan parameter. So residual long T2 can be myelin signal bias. Second challenging issue is long scan time. IR-UTE requires long recovery time, so TR is almost 1 second. To shorten scan time, we use the multiple spokes for IR NSP. In general, we use the 20 NSP, so total scan time is 10 minutes. If we use NSP, 60 NSP to shorten the scan time is reduced to 3 minutes and 20 seconds. However, this widened window making impossible to fully suppress long T2 signal. To address this challenge, we proposed the TIRI-UTE method. It is similar to a view sharing method. First, we acquire 60 NSP, and the only 20 spokes near the target TI are used full data for reconstruction, and spokesbar from our target TI are used only high frequency to improve image resolution. Because K-space center reflects contrast, and outer is reflects resolution and sharpness. In addition, we use the bit reverse ordering, so randomly acquired spokes are always uniformly distributed. As you can see, left and middle images are acquired conventional IR-UTE using NSP 20 and 60. Right one image acquired purpose method. Although reduce scan time, middle image, but overestimated compared to NSP 20. However, proposed method showed similar result compared to NSP 20. Next, TIRI-UTE also addressed T1 operation problem. We set a slide. We set the window to control contrast. We can move this window in time. Therefore, we obtain a TI resolved image without extra scan time. And during the reconstruction, the optimal TI is selected voxel by voxel, so we can maximize the myelin enhanced contrast image. This is a TI resolved image. Here, as you can see, minimum TI value varies depending on the location. So we apply TI resolved image to create myelin proton density map in an AD brain specimen. We generated 21 images with a target TI from 110 milliseconds to 220 milliseconds, and computed myelin proton density map. As a result, high ADNC shows a lower density, myelin density than intermediate ADNC case. For scan time comparison, conventional IR-UTE using 1 TI, so we repeat the 23 times scan, so it takes 3 hours, 50 minutes, but TIRI-UTE is just one scan, it takes 3 minutes, 20 seconds. So in this study, we shortened the scan time of IR-UTE without losing contrast or resolution. Therefore, a TI resolved image for voxel optimal TI selection is robust to white matter T1 in homogeneity and inter-subject variability. This approach may be useful in multiple sclerosis, Alzheimer's disease, and epilepsy. Optimization and validation of TIRI-UTE in neurological disorder are ongoing, and patent work in process with Ghasemiesfe. Thank you for attention.
Thank you, Dr. Park. Time for one question. Anyone? Well, in the interest of time, I think because we're running so late, please approach Dr. Park during the poster session for if you have further questions come up. And we'll move on to our next talk. And I must correct myself earlier, I said it was all PhDs, but we have Dr. Yasser Abdelhafez, who's MD, but he's an honorary PhD because he hangs out with all the PhDs all the time. So we'll treat him as an honorary one. He's going to be talking about total body PET-CT evaluation of myofascial low back pain preliminary results using dual tracer parametric imaging.
Thank you. Thank you for the introduction and for the opportunity to present this work and evaluation of myofascial low back pain using total body, dual tracer, multiparametric approach. So the myofascial pain syndrome is a quite prevalent soft tissue disorder characterized by presence of trigger points, taut bands, and refer pain. It could be primary, but more commonly it's secondary to or coexisting with other conditions, especially in, with spinal pathology. And that relationship is multifaceted, which could involve both biomechanical changes and also neurosensitization. The diagnosis largely clinical, depend on palpation of taut band, on reproduction of pain. However, it's largely subjective with moderate validity. More objective tools are being explored. However, they mostly lack the molecular specificity, an area where PET can fill the gap. So the theories behind the initiation and maintenance of trigger points are really evolving. Research suggests that there is excessive muscle activity or contraction due to sustained segmental sarcomere hypercontraction, and that leads to subsequent capillary constriction and ischemia, with subsequent energy crisis and release of sensitizing inflammatory mediators. So with the tissue perfusion and metabolism here could be playing major part of the cascade of events in here, we thought that measuring blood flow using carbon-11 butanol, which is a freely diffusible alcohol, and consider the reference standard for blood flow, and measuring also the tissue metabolism using FDG could provide biomarkers for myofascial pain. And another aim was to look at the blood flow measures from the FDG and compare it to that of the reference standard. So for this purpose, we recruited patients with chronic low back pain and one palpable nodule or taut band, excluded a lot of confounding conditions, mostly in the inflammatory diseases. And our subjects completed multiple questionnaires, including where is my pain, and they were scanned. 2/3 of them were scanned using a one-day protocol where the butanol and FDG took place in the same day, and we reconstructed high temperature resolution frames in the order of 1 and 2 seconds. With that high temperature resolution, we were able to, thanks to Dr. Wang's team here, to measure the blood flow from both tracers, and also we looked at the path-like Ki from the FDG. Since the patient pointed out their pain on just like a diagram, we need to map these locations to their corresponding regions. And we segmented multiple muscle regions on the CT. Initially, we thought to use some areas that are known not to have trigger points like the calf as background. And here's our results. This study was concluded with 46 patients, and they are mostly females with a median age of 51. We get a total of 130 painful regions. The majority of them were in the lumbosacral region and bilateral. So all the tested regions here showed higher blood flow and mostly lower metabolism compared to the reference calf region. And then we thought that could change by pain status. However, still this was persistent when we compare painful versus non-painful sites. And the dark color here refers to the painful side. Then we compared directly the painful and non-painful sites, but still we couldn't find differences except for a small trend in the thoracic paraspinal region in here. Those who have bilateral pain, the derived metrics were not significantly different between the one side with more or less pain. And this is an example actually where subject pointing out bilateral pain, referring more to the left side, while or to the right side, while actually on the butanol blood flow, we can see the opposite. So these findings suggested that we may need a more complex model that can capture the nesting nature of this data. And on mixed modeling here, we found that patient-level characteristics such as age, the presence of kyphosis, and facet arthropathy were independently and significantly predictive of muscle blood flow. However, pain itself was not a predictor, but this is not the end of the story. We found that pain and muscle region interact together, and that painful region within certain muscles like gluteus medius and maximus in here show significantly lower blood flow compared to other regions. The second part of or aim of this work was looking at how the flow measure from FDG could correlate to that of butanol. And to the top here is the blend outcome plot, and you can see that most of the points, regardless where they're coming from, are within the limits of agreements. And generally, the difference was less than 5% between the two measurements, except for the thoracic region where it's reached close to 15%. We also looked at the protocol. So for those who has one-day protocol, the measures were very close to each other, while those on having two-day protocol, there was significant difference between the measures from FDG and butanol. So in conclusion, though we were able to measure blood flow and metabolism within multiple muscles, we did not find any significant difference when directly comparing patient-reported painful and non-painful regions. However, we found that pain effect might be modulating flow in some region, such as the gluteus in here. And the other side of a story is that FDG measures of blood flow correlate well with that of their standard. However, this difference also could vary by muscle group, and further evaluation is needed to see what other factors could be playing in here. In the future, we would like to tweak further the mixed model to account for the nesting nature of this complex relationship in here, and probably expand beyond the collective core muscles into one region and expand that into individual muscles. And we would like to also visually evaluate the image findings from FDG. And with that, I conclude my presentation. Thank you so much.
Thank you, Dr. Abdelhafez. Any questions? I see one over there. Could you use the desk mic, please?
Hi, thanks for the very interesting presentation. Were all patients measured, was blood flow measured with the patient in the supine position and in all cases? And do you think the compressive effect of laying supine could affect blood flow to more superficial muscle groups like the gluteus medius and maximus?
That's a good question. Thank you. So yeah, the protocol involves that all subjects were lying flat on the bed. And in the past, we noticed that Generally speaking, regardless of the tracer, we see areas of discontinuous perfusion almost at the pressure points only. So that happened, yes, but we didn't see that extending beyond the skin and subcutaneous tissue, generally speaking.
Thank you. Let's thank the speaker one more time. And that concludes the profit abstracts part of the program here. We're going to now move to the abstract and other competition awards, which Mike is going to tell us about.
All right. Well, thanks again to all of our presenters, both the oral presentations and all of the e-posters and physical posters we're going to see. So yeah, it's my honor to present out our awards. So first, we have the best abstract by an undergrad student, which goes to David Melnichuk. Don't know if he's here, but his abstract was assessing diffusion models, denoising PET images, and their lesion detectability with numerical model observers. Looks like not here, so we'll get this to him later. And by the way, we do have $75 gift cards for all of the prize winners. All right, well. Next is the best abstract by a medical student, which goes to Victor Lamb. So come on up, Victor. For validating a study of pulmonary nodule measurements using ultra low dose helical CT scout imaging. Congratulations. Sorry. Thank you. All right, next up is best abstract by a graduate student awarded to Ishika Baumik. Congratulations for a framework for assigning image quality descriptors to clinical CT images. Congratulations. Welcome, come on over. All right, next up, best abstract by a resident awarded to Kaylin Griffith. Come on. She's still here, there she is. So abstracts entitled Current Landscape of the Use of Generative AI in Diagnostic Radiology Residency Applications. Congratulations. All right, now our final award is it's the best abstract by a postdoc or a fellow awarded to Shivani for evaluation of FAPI-74 total body PET as a quantitative biomarker for fibrosis staging and MASLD. Congratulations. Okay, now it's my honor to award the winner of our Shark Tank competition. Don't show yet. Don't show it yet. I got it. So again, thank you so much to all of our sharks for participating. Thank you for our presenters. And without further ado, I will award the $50,000 to Dr. Mike Larson. Congratulations, Mike.
Sharks up here as well, please. You should be in the front. Yeah. Oh, there you go. Thank you. So we're almost at the end and ready for drinks, which I'm sure everybody's most anxious for, and posters too, of course. So first of all, I'd like to thank everybody who's participated, the audience, the presenters, and the other organizers as well. One person who was not named earlier, who should have been named, is Ramsey Alizadeh. So he actually coded the abstract system, which saved us so much time. So he didn't get a mention earlier, he should have done. Thank you so much, Ramsey. You saved us a huge amount of time. Now, we're about to move to the poster session. There are electronic posters and there are physical posters around the wall. The electronic posters, you can decode who is going to be where. You'll see letters on above each of the screens, and those letters are then reported in these trifold booklets. Be careful, especially poster presenters, because they're not entirely in alphabetical order. We had to do a bit of jiggling around because some people had to present more than one poster. So do check, for example, the first letter is A, the second letter, which is Dr. Byerline, is P, not B, and that's not a typo. So please do double check that in there to find out where you're going to be presenting. I will leave this then for you all to enjoy the food and drinks and the posters with one last thank you to everybody who helped. Thank you very much.